Hello, I am live here today. You can ask any question if you have any patients or in their patients you are facing any issues. You can ask and you can may join my live. So in live we'll talk about the pulmonary embolism. So what is the pulmonary embolism? Basically the pulmonary embolism is the arterial obstructions. So obstruction in the pulmonary artery whenever happen, patient have the difficulty, breathing difficulty, hypoxia and all. So it's a most common cause is the deep vein thrombosis. Other causes include the thrombus in the any arteries, any DVT that can reach to the lungs and pulmonary artery. There is caused the thrombus. So risk factor includes the workout rates that include the venous stasis that will show the embolization, prolonged ICU stay, post-surgery, long travel, especially in the flight travel is the very high risk for the developing the deep vein thrombosis. Then the endothelial injury. How that endothelial injury cause? It caused due to the trauma, surgery, and central line sometimes. Then the hypercoagulable state. So hypercoagulable state, endothelial injury, and venous stasis. These three are the causes for the DVT, and it is factor at it called as the Virchow triads. So what the clinical features patient will have in the when the patient will have the pulmonary embolism. So they will have the sudden dyspnea, tachycardia, pleuritic chest pain, hypoxia, syncopal attack, hypotension, and signs of DVT. So that is the hypoxia and tachypnea, tachycardia. So, DVT can be, this pulmonary embolism can be classified into the massive or high risk, then submassive and low risk. So, how we identify it's the massive or high risk when the patient will have the hypotension, significant hypotension, patient will be in the shock, there are chances of high mortality. The submassive BP will be the normal, then patient will have the RV dysfunction. So, what will be the low risk? Patient will have the hemodynamically stable. Little hypoxia will be there, tachypnea will be there, but no RV dysfunctions. So how we diagnose? We do the clinical probability that include the Wells score. So D dimer uh, is the rule out. So it has very positive predictive value. So it has very negative predictive value. Its D dimer is negative. There is very less chances of the DVT. Then CT pulmonary angio is the gold standard for the pulmonary embolism. So investigation we do is the ECG that show the sinus tachycardia. Sometimes we see the S1, Q3 and T3. AVG most likely we see the hypoxia. So how we manage the pulmonary embolism? Initially what we do, we stabilize the patient, we give the oxygen, take the IV access, cardiac monitoring, vasopressor. Sometimes require the vasopressor when patient will have the massive PE. In the case of massive PV, the patient will have the hypotension in the shock. Those patients we need to thrombolize also with the anticoagulants. So other anticoagulation we can use these the enoxaparin or low molecular weight heparin. Sometime a patient has the renal failure or unstable, we have to use the unfractionated heparin. Then in stable patient we can use the DOACs. So thrombolysis, what is the indication is the hypotension and shock. Sometimes we use the LT-plage when patient has the massive P and we need the thrombolysis. So with the LT-plage, we thrombolize the patient. If patient is stable and thrombolysis is contraindicated, then we can do the embolectomy. Thank you. If you have any query, you can ask me in the chat box. Thank you.